Good morning, and thank you all for coming to the Evolution of CF Nutrition, a review of emerging evidence. Right. I got to get everything figured out. I'm Amanda Leonard, one of the moderators, and I have nothing to disclose related to the presentation, and neither does my co-moderator, Cynthia. So we wanted to talk about today the nutrition landscape and how it's been changing in the era of highly effective modulators. The CF Foundation is working on guidance for people, and so we wanted to get a summary of some of the new guidance that's been coming out. There really is a changing paradigm in people with CF, and there's limited available nutrition data as related to highly effective modulator therapy. So for a lot of things, there's not enough data to sort of say for sure what is going to work. So we're really focusing on individualized approach. And also I wanted to note, and this will be talked about more, that weight-related topics can be very sensitive. That was our disclaimer at the beginning. So when we look at guidance, the CF Foundation has a few different types of guidance that come out. The clinical practice guideline and consensus guideline statement are what you typically think of where there's a literature review and there are recommendations that are voted on, and there's usually good data to back it up. In recent years, they've added some more technical standards, position paper, state-of-the-art statements, and also clinical considerations. Cindy Brady and Sarah Hempstead and the CF Guidelines Committee made this great table that sort of summarizes all of the different things, and you can see, I don't think that my pointer works. But a clinical practice guideline has a panel of experts and PICO questions. It has sort of everything that's like the most rigorous. And then as you go down, things are a little bit different, maybe when there's not quite enough evidence available. And so you might be wondering, well, Amanda, why are you talking about all this stuff? That's because the two guidelines that we're talking about today, or the two different types of guidance, really came from a very different place. The first talk is going to be about lung transplant. And this was a consensus statement with a multidisciplinary committee, 3 different work groups. They have PICO questions, which I think Jess is going to talk about a little bit more, recommendation statements that were voted on, and it needs to have an 80% recommendation to pass. The other talks are about a nutrition position paper. And the difference between the two is that the nutrition position paper, still a multidisciplinary committee, and we had work groups, but there were no formal recommendations. It was just expert opinion, and it's meant to address a really narrow scope with sort of the highest priority topics. And even when I was on the committee, and it's almost like disjointed topics because it was the questions in the community that they needed to be answered. So I wanted to give a little bit of background because each speaker's going to concentrate on their specific recommendations, but I wanted to give a little bit of an overall background for where the different guidance areas are coming from. Okay, and that's actually for the end. So I'm going to go back.
Thank you so much, Amanda. Good morning, everyone. Hope everyone is enjoying the conference. Maybe very soon we will be doing the clinical guidelines with the emerging evidence in the coming years. So let me take the pleasure of introducing our first speaker, Ms. Jessica Leonard. She's a senior clinical nutrition specialist in Department of Clinical Nutrition, Boston Children's Hospital, Boston. She works with pediatric patients with CF and also patients undergoing lung transplantation. She attended Emerson College and completed a bachelor's in print journalism and public relations. After working in marketing and public relations for 10 years, she returned to school at Simmons College and earned her certificate of dietetics. She completed her dietary internship through the Sodexo distance program, and she currently working with, as I said, CF and lung transplant population for the past 9 years. And she also holds additional certifications such as CCTD, CSP, and CACFD. Thank you so much, Jessica, for this talk.
Great, thank you so much for having me. I'm going to apologize because I can barely see you, which means you've probably just got like a halo of curly hair happening. But the dry heat here is working for my hair, I gotta be honest. Okay, so today we're gonna talk about the nutrition management of cystic fibrosis lung transplant recipients. Okay, you said this one, right?
Yes.
There we go. Okay. I have no disclosures, and I realize I didn't put my hospital here, but I am at Boston Children's Hospital. Our objectives today are going to be to recognize nutrition considerations for CF lung transplant recipients as outlined in the CF Foundation consensus statement, and also a little bit on how to apply these considerations in both the short and long-term management of CF lung transplant recipients. So I think it's important to take a little bit of time to talk about or sort of frame this out in what the consensus statement is and what it isn't. And this is sort of what our intro was alluding to as well. So the audience here, the group that we were looking at was our CF lung transplant recipients. And the objective of this consensus statement was to provide recommendations to CF and lung transplant clinicians for the management of perioperative and underlying comorbidities of CF lung transplant recipients and the impact of transplantation on these comorbidities. The audience here was meant to be or is meant to be both transplant practitioners who may not be trained in cystic fibrosis care or maybe have not practiced in it recently, as well as CF practitioners who may not be trained in the care of solid organ transplant patients. As Amanda mentioned, this was a multidisciplinary team of pulmonology, infectious disease, GI, endocrine, transplant coordinator, myself as the dietitian, pharmacist, psychologist, transplant recipient, as well as a caregiver. Okay, so if we're going to talk about what it is, we're also going to talk about what it isn't. This is not a consensus statement that is all-encompassing about how to care for a post-transplant patient who has it. Is not covering food safety. It is not covering anything that would be the same for a CF patient as it would be for a non-CF patient. So food safety is something we educate on in both realms, so that's not something that was covered here. Also, things that have other guidelines, this was not general advanced lung disease management or about transplant referral. And I threw in your little clean, cook, separate, chill, just to jog that brain of food safety fun. It is still a big part of what I do. It just was not part of what this consensus statement was about. The three nutrition recommendations that were part of the statement, the first being ongoing consultation with a dietitian with CF experience. And I think as we were doing this, and the PICO question review and everything that happened for the statement was around 2018, 2019. So we knew we were edging into modifiers. So some of these are a little vague, but it's really speaking to the fact that I think this idea of individualized approach is something we're on, day 4 of the conference now, you've been hearing throughout the week, and is so important specifically in a transplant patient. Because we want to, and the statement says, to achieve an established BMI or weight for length goal. And that's really saying that the dietitian and the patient are meant to be working together and understanding what that goal should be. Is it necessarily the 50th percentile or 21 or 22? That's to be figured out by that group and see what makes sense for that patient. And that's the clinical practice and judgment of the dietitian, as well as understanding what the goals of the patient are. We do recommend continuation of vitamin D supplementation, but discontinuation of the CF formulated vitamins, so your ADEK vitamins. And the reason for that is that there is an incidence of high vitamin A in post-transplant CF patients. It's in fact not unique to CF patients. It's all post-transplant patients, lung transplant. So with similar to when we look at these levels with inflammation on board, which is also something that's going to be happening in the post-transplant period, we don't want to supplement on top of a falsely high level. That said, we don't want to lose track of these vitamins that have been stopped. And this is sometimes where you're also getting a patient who may be leaving their transplant care center and coming to their CF center, or vice versa, or moving their care into their transplant center. So it is an important question to ask of what vitamins we're doing. and that we're going to measure those at about 3 months post-transplant. Again, if it's not clinically a good time to get a good level, then that's free to make that, but we'd like by 3 months to have that. So then we can understand if we want to restart those CF formulated vitamins, or in fact, do we want to individually replete? And that's going to be guided by your lab values. So those were the 3 main nutrition recommendations under that heading within the consensus guideline. But there are places where there's crossover, right? We all work together. So in the GI nutrition, GI section, we have this other statement that is stating that CF lung transplant recipients who experience new or worsening symptoms of gastrointestinal dysmotility, it is recommended for them to have a consultation with a gastroenterologist and a dietitian with CF expertise to guide symptom control interventions. And I think this is important because we as CF dietitians are going to view these symptoms and their management a little bit differently than someone who maybe isn't versed in how to manage enzymes or how to really kind of live the CF life. So it is important. One of the things that really was a big highlight, and I was in I kind of called it like the everybody else work group. But this idea and statement of someone with CF experience was a big piece of what we looked at and how we drafted these statements, because it is a value that we're bringing and a viewpoint and experience. Another one that's an overlap here is the recommendation for bone density to be assessed by DEXA at 6 to 12 months after transplantation. And that is also because your transplant patient is going to be on steroids as part of their immune suppression regimen, and therefore is going to make them more vulnerable to bone disease. We know they're already at risk for bone disease, being a person with CF, but this is an additional piece. So we want to make sure that 6 to 12 month timeframe is where the DEXA is being done and then tracked from there. Now, the interpretation of it and the interventions that may speak to it, that's going to need to be done in concert with an endocrinologist who can read and, bone age those DEXAs, but we are also have a role to play there. All right. So thinking a little more about when do we think about these things and where do we go with it? In the short-term management, the nutrition prescription, establishing that, monitoring it, adjusting it accordingly is, such a cornerstone of what we do as dietitians, and it continues to be the case in the care of a CF lung transplant recipient. We generally assume that the predictive equations are going to underestimate needs, and we also are thinking about a gradual decline of energy needs in the post-transplant period due to decreased energy expenditure from decreased pulmonary demands and ideally improved appetite. Now, can I say all of these things are going to happen for every single transplant patient? Absolutely not. But they are things to be asking questions about and understanding a little bit better. Also, any movement of steroid medication can influence appetite and weight gain and that sort of thing. So that's also a piece of where you're monitoring and adjusting what's happening over time. As I said, we're going to restart the vitamin D. That should ideally be done in the hospital. And again, this is only if they were on supplemental vitamin D beforehand. You're not putting it on anyway, or just as a course of treatment. But if they were on it prior to transplant, you would restart it and also try to watch your levels from there. And that we're going to hold those CF formulated vitamins until about 3 months when we can check those levels. Long term, the CF Foundation is recommending that CF lung transplant recipients follow up with a multidisciplinary CF care team within 6 to 12 months of transplant to resume that extrapulmonary CF care, and that communication between the transplant and CF care teams is essential for coordination of care. I think these two pieces right here, I think sometimes we as dietitians are I always say, like a strange area of continuity. We hear and we see and we know what's going on with our patients, and we may be the one who was there before transplant, after transplant. And for me, I am in a center where those two things are entirely integrated. So for our group, the transplant team picks up the CF care after transplant and continues to be their CF doctors afterwards, even if they're coming from a different center. Now, I know I learned while I was on this consensus group, that's not the model in most places, but it was the only model I had experienced with. So it was interesting to hear other people talk about how that, often they're having patients go to different clinics and come back to them, or maybe they're not coming back in that 6 to 12 month period. But as we think about transplant and what that means for their care and their home CF team, it is meant for them to come back in that 6 to 12 month. But as I was talking about time frame, right, we're saying at 3 months we'd like to have those vitamin levels checked, but we're not telling them really to come back to CF clinic until 6 to 12 months. So if there is an overlap there, I think that is a little piece on timing wise that is a nuance to think about. CF Foundation is also recommending screening with an oral glucose tolerance test at 3 to 6 months after transplant, and then annually following the recommended screening guidelines for CFRD. So as a transplant recipient, they, again, are going to have exposure to steroids that can make them more vulnerable to blood sugar fluctuations. And a lot of patients are also on tacrolimus, which can also induce diabetes. So on top of being a CF patient or person with CF, there are sort of 2 additional hits that could be coming in the control of their blood sugars. So really making sure that if this is a patient who did not have CF-related diabetes prior to transplant, that it is something that you're monitoring for and asking those questions of how the patient is feeling and some of those other symptoms that can come along. All right. And the other piece here is this, as I said, this was a eye-opening experience for me to understand a little more about how other centers work and what transplant means there. I am recognizing I'm fortunate to be somewhere where we have a lot of other specialists associated with our CF team and where those things are integrated. But we do have partnerships here to establish with whether it's GI or endo or ENT or psychiatry or transplant coordinator, clinic or home nursing. These are people who are with the patients quite frequently. And I don't know about you, but I have had my PT come to me. I've had my social worker come to me and be like, did they ask you about how to fuel for exercise? And I'm like, no one said that to me in the hour that we were talking. So I think having this communication, and like I said, my people are all in the same place, send that email, ask those questions out to the other team. You'll know that you asked, right? I don't think anyone's ever going to mind if you're like, did you change the steroids the last time they were in for their transplant visit? Because we're noticing XYZ, and that would really explain this. But I think in transplant care, you have to be collaborating. You have to be having partnerships with everyone. PT and social work also, if we have patients who are trying to get back to activity levels that they maybe haven't been at since their teen years, they are going to need to fuel differently than they have in the past, and also whether or not we're in a place where we're going to be starting modifiers. The consensus statement at the time that it was done did not have enough evidence to suggest for or against use of modifiers in the lung transplant population. So I can't speak to that, but I also wanted to highlight other places that we can get answers, right? So I talked a bit about what this guideline is and what it isn't, and there's just a lot that is in between all of these things that we want to know more about when we're trying to care for our patients. So I think, our CF listserv is such a great place to ask these questions, whether it's CF-related care or transplant care or a combination of the two, or even just difficult patient situations, right? Like, how have you counseled a patient in this sort of situation before? Not necessarily always unique to your transplant patient, but to remember that you have that as a resource. There are also 2 transplant listservs that are run through NATCO. One is pediatric and the other one is adult. It's all organs. But it is another place where I learn about different, QI projects people have going on, or things that they've seen anecdotally in 3 or 4 patients that you start to say, okay, I've seen that too. The pediatric one is run out of my group at Boston Children's, and we have about 250 members within that group. So again, doing all different organs and not CF specific, but a group who has a real focus on transplant. So that is kind of my summary statement, but I'm more than open. Are we doing questions now? Yeah. Sorry. Okay. Oh, great. Sorry. More than happy to answer questions and hear a little more about what you guys want to know about.
So we'll do about 5 minutes of questions after each speaker, and then at the end, we'll have everybody come up if there are more questions to be asked. So you can ask questions on the app, or you can come up and do it on the microphone.
Hi, Jess.
Hi.
So I have two questions.
Yes.
One is, so I know you said continue vitamin D. What about vitamin K? Do you find that that does not stay, like the PT does not stay elevated in these patients? Because I feel like the ones that do actually come back, which is not very many, to CF, but I do find that most of them need both D and K.
I will say I think the K is one that probably does have to go on. There wasn't enough evidence to make an individual recommendation. And I know vitamin K is that like tricky one where we say like check the lab, but like which lab and does your lab run that lab? And it's a fun little game to play. Or teach about in the vitamin K that got checked last week on my patient. I was like, that's not going to tell you anything. So I think it is, in my experience, it has been one that I've seen need to go back on, but there wasn't enough evidence to make like a precise recommendation against it. And I think that's where that other statement about like individually replete as needed was really meant to cover that, because we found, a few things here and there, but not enough to say summary, this is where we would make the recommendation.
Okay. And then my second question is, so checking like an OGTT like 3 to 6 months later, do you not find that most of the patients, because they're on the high dose steroids immediately, that they don't typically have elevated blood sugars immediately post-transplant and end up with like diabetes immediately post-transplant?
So I'll say I think the OGTT recommendation is a little bit of it's like a safety net, right? It's basically saying like don't forget about this piece of care, and that this is the test that we ultimately use. Now, I think we've all or maybe we haven't had experiences where we didn't do the OGTT, but we had so much blood sugar data to tell us, let's start managing this, that's going to go ahead and happen. I do think in my experience, it's probably something that's going to be seen, addressed, and treated in the hospital. But I do also have patients that have needed it coming out of transplant and 6 to 8 months later didn't. And that was probably more related to the fluctuation in their steroids in that immediate post-transplant period than anything else.
Excellent. Thank you so much.
Yeah,
Great
of
talk.
course.
Hi. I have a question about getting the vitamin labs after surgery, after transplant, I mean. So probably the hardest part for me is, we have these post-transplant CF patients, but the doctors don't have these vitamin labs in the order set.
Mm-hmm.
So do you personally put in the labs like for the vitamins, or is it already built in your order set? Like how does that go?
It's not built in our order set. I'm not allowed to put in the order. I generally will put it in my note and very specifically say, check this, and this. And then I hound my team until they do it. So it's not a very refined approach. I do have, and I am happy to share it again on the listserv. I do have like a clinic worksheet I had created a couple years ago when I presented on this topic more in the general before the guideline had come out, that I'm happy to use. I think the other thing too is this statement is something you can hand to your MDs and say, like, this is the recommendation to do this, right? I'm not the dietitian bugging you. I actually need this.
Yeah.
And I think when we say night blindness, people sort of they're like, no, but it is an actual thing, right? And it is important. And please know, like, I'm not joking because I think it's a light topic. It's more to say that I think in my experience, sometimes it's hard to quote unquote get taken seriously about vitamin labs.
Correct.
So
yeah, I mean, if you could share that in the listserv,
yeah,
that'd be great.
I'm more than happy to. I'll take a look through it and see if it needs any updates, but I think it's got some different things covered there.
Awesome. Great presentation.
Thank
by the
you.
way.
We have several online questions.
Wonderful.
The first one is from Juliana. Thank you.
Hi,
For an
Juliana.
excellent presentation, Jess. What is your biggest wish for going forward in future iterations of the care model for nutrition in lung transplant?
So, interestingly for me, I do pediatric lung transplant. We at Boston Children's have not transplanted a CF patient since 2019. I think that is both impressive and gives me a little bit of chills, but it also worries me a little bit in that our transplant docs and our trainees are not getting the exposure to what it means to both care for very sick CF patients. As I said in the intro, to have written that I've been doing this for 9 years was kind of crazy, but I think for those of you who have been here much longer than me, the snippet that I've seen of a time when I had a census of between pediatric and young adult, probably 15 to 20 CF patients in at a time. And now I maybe have 1 or 2. So I think in some ways it may need more detail as time goes forward. I think we may be in a place where we can't assume some knowledge or base knowledge is there, base understanding is there. One of the other things, and it's in the appendix of my slides, is for things that already had an existing consensus statement like bone health, like colorectal screening, I did include those in here as reminders of what those other guidelines are saying. So there's some stuff that's covered in other places and again, not unique in this patient, but that guideline already covered things. So I think this one needs to be revised, updated, reinvigorated.
The next question is from Dr. Henry Zalada, who is the endocrinologist. The question is, in patients with uncontrolled CFRD and post-transplant diabetes, is there evidence of safe number of carbs per day intake in these situations?
Short answer is no. Long answer is individualized approach. I think there is going to be a period of time where they're just going to be really hard to get under control. I think we go back to mixed meal components and depending on how different people choose to approach diabetes management, is it a patient that may benefit more from thinking about things in a glycemic index or glycemic impact load framework is probably going to be more than saying this many carbs is the cutoff and the no. Because I also have patients with really high blood sugars that need to gain weight. So you can only have so much without moving that carb number up.
Thank you. A question from Ms. Carissa Colley. Is there a listserv for transplant RDs?
Yes. Yeah, sorry, there's 2. There's a pediatric and an adult one, and I'm happy to post stuff to the listserv. I can put that on there. They're run through Google.
And a question from Stacy Fugati Brown. Who manages enzyme post-transplant? Does that change or stay with the CF center? I think we mean the patient.
Yeah.
Yeah.
It's really gonna depend on the center. Your CF dietitian is the one who's generally still gonna be your best expert for enzyme recommendations. So far, and as I said, this is not thinking about patients who have then gone on modifiers after transplant or who were on them beforehand. We don't have enough evidence there to say, is this going to make any change to their enzyme management? But I think it's having that person with the CF experience who can ask the right questions about malabsorption, about appetite, that sort of thing, and be watching that weight gain that's going to help with the management. But generally, the CF dietitian is the one making the recommendation.
I'm going to sneak one more question. If your patient has not been on a vitamin D supplement prior to transplant, do we recommend starting one? This is from Ms. Caitlin Otts.
So I always recommend going off your lab. I think if, a lower dose vitamin D is probably safe to start if you feel like I just can't get this lab on this person and they're in a place where they may need it. I think the addition of steroids and the focus on bone health and knowing that there's a high incidence of fracture in post-transplant patients is a good enough reason to start a small amount. But that's anecdotally my clinical judgment. It's not overarching statement.
We have a few more questions, but due to want of time, we can club them towards the end. Thank you so much for your nice presentation. So our next presentation is Dr. Juliana Bailey, who is the Senior CF and Respiratory Dietitian at Alfred Health, Melbourne, Australia. So this session is truly international. So her journey started with a bachelor's degree in nutrition and food science in 2009 from Auburn University. She completed her dietetic internship and earned master's in clinical nutrition from UAB in 2011, where she was selected to complete the maternal and child health Bureau-funded UAB Pediatric Pulmonary Center Nutrition Traineeship. She earned her PhD in Health Education and Health Promotion from UAB in 2021. From 2011 to 2014, she was the RD in Pediatric and Adult CF Center and Pediatric Lung Transplant Program at Boston Children's. She was the dietitian for UAB Adult Program from Adult CF Program from 2014 to 2023, where she joined the UAB Department of Medicine as a research faculty. In 2023, she moved to her current job in Australia. And Dr. Bailey has designed and led multiple clinical QI projects at both local and national levels, and also served on different roles in the foundation. And she has published numerous abstracts and manuscripts focusing on interdisciplinary QA work, experience of care, and nutrition research in CF. Let me take the pleasure to invite Juliana.
Thank you, Sunil. So I think most of you know by now that I've been struggling with not having a voice for this entire conference. Can everybody hear me okay? Good. All right. I'm going to do my best, and I apologize for sounding like this. Today, I have the pleasure of presenting an update from the CF Foundation Nutrition Position Paper on weight management and pancreatic enzymes. And this is a gigantic topic, so I'm going to do my best to get it all in the time that I have allotted. So I do have one disclosure related to this presentation. I am a scientific consultant for Anagram Pharmaceuticals. So to start off with giving a little bit of background, I think most of you are really familiar with this background at this point, but malnutrition was historically one of the defining features of CF. And with that, nutrition status has long been positively associated with lung function, meaning having a higher BMI was associated with having a higher lung function. This sort of led to a hyper focus on BMI and weight trends in CF clinical care practice because the CF Foundation had set BMI goals for these patients. This was a heavy focus every time patients came to CF clinic. So I just wanted to put that out there as sort of something to keep in mind as we move through this presentation. And BMI has long been the primary metric for measuring nutrition status in CF. And our legacy diet in CF is high in energy and high in fat, but with no recommendations on nutrient density or diet quality specifically. This was really born out of some observational evidence in the 1980s that patients who consumed a high-fat diet with CF and took enzymes lived longer than patients that consumed a low-fat diet and took enzymes. So as things have evolved rapidly in CF, we do have some updated dietary guidelines from the Academy of Nutrition and Dietetics, who recommends the intake of foods associated with optimal cardiometabolic health outcomes in the general population. These includes vegetables, fruits, lean protein, low-fat dairy, whole grains, and legumes. So this is a very general recommendation that in patients who are not at nutrition risk or struggling with malnutrition, to essentially, it's okay for them to eat the diet that is similar to age-matched healthy people in the general population. There was a recent systematic review that came out in 2023 after the publication of the CF Foundation position paper that looked at diet quality in people with CF compared to what was recommended. And what this found was energy-dense, nutrient-poor foods contribute to intakes which pose risk in developing diet-related chronic diseases in the CF population. In short, diet quality in CF is very poor. So we also now have an aging population with CF, and this is an absolutely wonderful thing. This is largely due to novel drug therapy and rapid improvement in clinical care. However, with this increase in life expectancy, the landscape of nutrition is really changing. Combined with the legacy CF diet and the widespread availability of highly effective CFTR modulators, we have these trends. I've put on the slide here some graphs from the US CF Foundation patient registry that graph weight and BMI in adults and children with CF. In the graph on the left, you can see children. We have BMI, height, and weight graphed, and you can see from 2001 to 2021, all of these growth parameters have been steadily increasing in our CF registry population. We see similar trends in adults with CF, with median BMI values for both men and women increasing from 2001 from 2001 to 2021. And you can see right there at the end of the graph, there is a sharper uptick when Trikafta or ETI was introduced to most people with CF. So I also wanted to bring up the change in distribution of weight groups from CF Foundation patient registry data. I also want to note that during this presentation, I'll be using the words overweight and obesity quite a bit. If you were in the talk before this, you understand that these words can carry immense stigma and shame, and that friendlier language to use, or more appropriate language to use, would be people who live in larger bodies or even fat. For the purpose of this presentation and a largely clinical and research audience, you will see the words overweight and obesity, so I just wanted to provide that disclaimer. So I also wanted to disclaim that when we talk about overweight and obesity in this population, we are using traditional BMI cut points. And I think we all understand that there are significant limitations associated with the use of BMI, which I'll speak to a little bit more later. So what this slide shows, though, is that obesity and overweight, represented by the yellow bubbles, have been increasing substantially in our CF population in both adults and children from 2000 to 2019. You can also see a concurrent decrease in the propensity of underweight in the blue bubbles over the same time period. Subgroups of this population with substantially higher rates of obesity included individuals age 46 and over, people who are living in a zip code where the median household income was less than $20,000, or who had at least one allele with a class 4 or class 5 mutation, typically known as less severe mutations. And also, obesity was more likely in patients who were prescribed ivacaftor and who were prescribed pancreatic enzymes. So during this period of 2000 to 2019, there were striking changes in the number of proportions and frequency of overweight and obesity, with the increase in the number of those who are overweight increasing by 300% and obesity increasing by greater than 400%. Also, this persisted when accounting for the increase in population in our CF registry data. So again, while we are talking a lot about BMI, we do need to look beyond the BMI. We've long been reliant on this as a marker of nutrition status, and I do want to briefly mention the limitations here. I have some headlines up here that you may have seen from earlier this year that came out after our position paper was published as well, that the American Medical Association has requested that physicians de-emphasize the use of BMI. And in this newly adopted policy, the AMA recognizes issues with using BMI as a measurement due to its historical harm, its use for racist exclusion, and because BMI is primarily data collected from previous generations of non-Hispanic white populations. So while this is a measure we have at the population level, please be mindful that it does have its limitation when you're assessing individuals in your clinical practice. To talk a little bit about obesity comorbidities, clinicians should be aware of potential cardiovascular complications associated not just with obesity or weight status, but even with the legacy high-fat, high-calorie diet, particularly in the setting of highly effective modulator therapy and increasing life expectancy in our population. So, in the general population, obesity has been associated with worse cardiometabolic outcomes. There is limited data in overweight and obese people with CF, but I've presented some of the associations here. In the pediatric population, they've found increased incidence of arterial stiffness and obstructive sleep apnea in overweight and obese children with CF. In adults with CF, there have been some associations with higher cholesterol, higher blood pressure, and increased insulin resistance in obese cohorts. When it comes to lung function, FEV1 was higher and pulmonary exacerbations were lower in people with CF who were overweight compared with those who were normal or underweight. However, there was a ceiling or a plateau effect, meaning that these things didn't exponentially get better as BMI got higher. It eventually leveled off. So recommendations on nutrition should take this into consideration, and also with the context that with this possible plateau as BMI increases, an increased BMI association with improved lung function can hit an upper limit. This is yet to be defined. I wanted to also touch briefly on management of obesity in the general population. Our position paper does direct clinicians to consider what is available for the general population, given the paucity of evidence around treatment or interventions for overweight or overnutrition in people with CF. I've made this little graph here about general population guidance for management of obesity, which starts with lifestyle changes, including diet, exercise, and behavioral modification as the first line recommendation. If this is unsuccessful, or if patients have a BMI higher than 30, pharmacological therapy can be initiated. Or if patients have a BMI greater than 27, with at least one obesity-related comorbidity, pharmacological therapy can be indicated. And for surgical intervention, I've put down here on the bottom the criteria, which are, again, based on BMI. And at the lower BMI cut point of 35, there does also need to be the caveat that there are obesity-related comorbidities and lifestyle changes have been ineffective. I wanted to note that this is not a recommendation to apply to the CF population, but I did want to make people aware of recommendations available for the general population, which also do have their limitation. GLP-1 receptor agonists are a really hot topic right now. Many are being recommended in the general population. I think it's hard to turn on the television or scroll social media without being bombarded with this. And it's being prescribed to the point of global shortages. Obviously, surgical management is a very invasive option for weight loss in response to obesity. And it should also be noted that diet, exercise, and behavioral modifications have not been associated with long-term or sustained loss or maintenance of weight loss that are achieved through these methods. So as far as medical and surgical management in CF, again, we do not have evidence on the safety or the efficacy of currently FDA-approved weight loss medications in this population. Anecdotally, they are being used in our population. I wanted to emphasize here that these drugs may exacerbate symptoms of pancreatic insufficiency, worsening malnutrition, and leading to multiple micronutrient and essential fatty acid deficiencies. They can also worsen a host of other pre-existing GI conditions present in the CF population outside of pancreatic insufficiency. There likewise is no solid evidence for safety or efficacy of bariatric surgery in CF, although there have been some case reports. It is really essential that shared decision-making be employed if you are going to consider pharmacological or surgical management of obesity and CF with your patients. There is not evidence to suggest this to patients, but I recognize that some patients are coming requesting these things to clinic. As it was so eloquently presented in the session before this, we live in a society that places a lot of emphasis on a smaller body being desirable, and this creates a desire for weight loss in people because of weight stigma and shame associated with living in a larger body. So if you haven't already, I'm sure you will have people coming to you asking about these things. And it's just really important to make this a collaborative conversation and to provide patients with really informed consent on not just the benefits, but the potential for severe side effects that come along with these things. Given what's known about nutrition risk in the CF population, bariatric surgery might not be an ideal option for people with CF until more evidence is available. And a lot of these procedures are permanent and can lead to worsening permanent consequences related to malabsorption in our population. Did want to touch briefly on weight stigma. There have been multiple talks about this at the conference that said this so much better than I ever could, but I wanted to present it here as well, that obesity is highly stigmatized in our society, including in medical settings, and patient experience of weight stigma can lead to them avoiding care. So weight stigma in overweight and obese individuals is positively correlated with increased cortisol levels, diabetes risk, eating disturbances, depression and anxiety, and body image disturbances. Evidence shows us that weight stigma is also negatively associated with self-esteem. So please keep this in mind. I would be remiss in a talk about weight management in CF if I did not also mention weight neutral approaches, which our position paper also touches on. Body image and disordered eating in CF is well documented, and our next talk is going to go into a lot more depth about that and go over what the position paper has to say about it, so I won't touch on it too much. But again, I do think that this is heightened by the intense focus on weight at regular intervals since birth in this population. I often ask other clinicians, can you imagine if you had gone to the doctor every 3 months for your entire lives and had a team of people talk to you and your parents about your weight and whether or not you were hitting a goal? It'd be pretty hard. So there is also some evidence that suggests that the influence of eating experience in early childhood also persists into adulthood. There can be a lot of damage done to the relationship with food at a young age because of this hyper-focus on weight. Some people with CF may prefer a weight-neutral approach. A lot of people in the general population prefer this approach as well. Just to give a quick definition, weight-neutral approaches are focused on improving physical, behavioral, and psychological parameters rather than promoting weight loss. These approaches also emphasize body acceptance and neutrality and improving individuals' relationship with food. There is some evidence on weight-neutral approaches, believe it or not, and I do not have the time or bandwidth or voice to present. This could be a whole hour-plus talk on just the evidence on weight-neutral approaches in the general population, but to give you a little bit of taste for it, there has been a meta-analysis recently on weight-neutral approaches versus traditional weight loss that found that weight-neutral approaches are as effective as weight loss methods for improving physical, psychological, and behavioral outcomes in the general population. Randomized controlled trials of weight-neutral approaches have shown benefits even in the absence of weight loss, and these include reduction of LDL cholesterol, reduction in waist-to-hip ratio, improvements in diet quality, increased physical activity levels, and improved quality of life and self-esteem, which is what we all want, right? This is something that every discipline is working together for with our patients. So I also wanted to bring this caveat with weight-neutral approaches. Sarcopenic obesity and lean body mass depletion have been documented in our population. This means that somebody can have a normal body weight based on BMI standards, but have very low muscle mass. This is also associated with poor pulmonary functions and other CF clinical outcomes, even when controlling for BMI. It is unclear if weight loss interventions in people with CF will result in predominantly fat loss or whether this will cause further reductions in lean body mass and worsen already present body composition abnormalities that have negative health consequences. There are no studies on weight neutral approaches in people with CF, and these are desperately needed. Another bit of evidence that has come out since our position paper was published that I found very interesting was a qualitative study out of the UK on clinician views of management of obesity and CF. This group conducted semi-structured interviews with 20 clinicians working in 15 different CF care centers across the UK. They interviewed 8 dietitians, 6 physiotherapists, and 12 physicians to explore their perspectives and current practices in caring for people with CF who are also overweight and obese. They had some themes that emerged. Excuse me. There were challenges with raising the topic of overweight and obesity in the CF clinic. These clinicians identified a hesitancy to bring it up due to weight stigma and also concern of damaging rapport if you're a clinician pointing out to a patient, hey, your weight's really gone up since you've been taking Trikafta, this might not be good. The changing landscape of CF nutrition assessment due to CF-specific causes of weight gains, such as a historical energy-dense diet coupled with CFTR modulation therapy, was also something that clinicians highlighted as a challenge. Another theme that emerged was the presence of clinical equipoise for weight management due to lack of evidence on the clinical consequences of obesity and intentional weight loss in CF. It is unclear, there are unclear consequences around respiratory outcomes and the risk of weight-related comorbidities in our population. This is a relatively new phenomenon, and we have very limited evidence on this. The final theme that emerged was opportunities for safe, effective, and acceptable weight management treatment for people with CF, and really that there needs to be emphasis on the collaborative work with the MDT. So if you're a clinician working with CF, you can probably relate to all of this that came out, but it is always nice to see it presented as evidence in the literature. So we really do need interdisciplinary management. And I think that we cannot emphasize enough patient-driven shared decision-making on the topic of weight management in CF. One size doesn't fit all. And I won't read this to you, but I did want to bring in from the A&D CF nutrition guideline the role of the dietitian or international equivalent and what we can bring to the table in helping to create customized nutrition care plans for our patients, taking into consideration not just physiological needs and health status, but also cultural, preferential, and patient-centered goals. This table is hard to read, but I wanted to include it. This is from our position paper, and it is a table that outlines each discipline's roles as far as addressing weight and nutrition approaches and food insecurity assessment in the CF population. And so I wanted to also note at the top of this is the patient and family, because they are the captain of the team, and our interventions really need to be informed by the patient and family goals and what they want and what resonates with them. And to bring it back to our evidence, even if somebody desires weight loss, even if this is what the patient wants, evidence shows that the most successful interventions are those with which a patient identifies that they can adhere to. And then just very quickly before my time's up, our position paper did also touch on pancreatic enzyme replacement therapy. And I wanted to briefly highlight that there is some emerging evidence that suggests the restoration of pancreatic function is possible in children with CF. I've included a graph here from the Kiwi and Klein studies that shows an increase over time in children with CF on ivacaftor in their fecal elastase levels, reaching close to pancreatic sufficiency. There have also been case reports of pancreatic function returning later in childhood on highly effective modulator therapy. So it's helpful to check a fecal elastase in children on modulators up to age 5. But it is important to not just do one and done. You probably want to keep monitoring this because it can take several years for pancreatic function to return. And then finally, for patients on enteral feeds, which we're seeing less and less of, use of an inline enzyme cartridge with immobilized lipase has been shown to be safe and effective for digesting nutrients and promoting weight gain. Sorry. So in conclusion, you've heard it 1,000 times now. I'm sending it home again. Nutrition care should be individualized, and please, individualized around the goals of people with CF. Clinicians should consider potential cardiovascular complications associated with the legacy diet, and we should also focus on improving diet quality. More evidence is needed regarding the impact of obesity in CF on clinical and quality of life outcomes. Clinicians should be cognizant of weight stigma. And for enzymes, the inline enzyme cartridge is safe and effective. We have a lot of limitations to our current evidence that I feel like I've talked through around this entire talk. So I'm not going to read you this slide, but it is here for your reference. And for future directions, further studies are needed on the adverse cardiometabolic effects of CF, as well as the effect of different dietary patterns to promote heart health in our population, and what the impact of outcomes of these different dietary patterns is. Work's needed to understand the impact of weight loss interventions for obesity in people with CF, given our body composition abnormalities present in this population. And finally, more research is needed on comprehensive health behavior interventions, including weight-neutral approaches to improve cardiometabolic outcomes and quality of life in our population. I have my acknowledgments here to the CF Foundation and the committee that worked tirelessly on this position paper for a year, including Cynthia and Amanda, and many of you that are sitting in the audience today. Thank you for your time.
Thank you so much, Juliana. We have several questions. The most popular question is from Maria Santini. How do we reconcile CF guidelines with the American Academy of Pediatrics guidelines for pediatric obesity and the messaging from primary care doctor versus the CF care team, which has been historically been a challenge?
What a loaded question. I love it. And it is sort of an elephant in the room. You know, I think that we should be leaning into guidelines that are specific for our population. And when we don't have evidence-based guidelines, leaning on the clinical expertise of CF clinicians, as well as the lived experience of our patients and families with CF. Your question brings up a really good point about partnership with our primary care teams. As we move into this new model of CF care, I believe we're going to be relying more and more heavily on primary care in this aging population for screening metrics. And so I think this just really speaks to have primary care physicians that have close relationships with our CF care teams. And we're going to be doing a lot of education with primary care. We in CF are accustomed to educating other providers in different subspecialties about the nuance of CF care, and I believe primary care will be no different.
Hi, thank you very much. That was a really great talk. I particularly like, I'm Ina from Ottawa. I'm the cystic fibrosis nurse there. And I really like your comments about focus on nutrition and eating entire lifespan of a person with cystic fibrosis. So it's really hard to turn that around. But my question is, and it might have already been addressed somewhere at the conference, but a room full of dietitians, I'm sure I can get an answer. So we know that SSRIs block receptors in the hypothalamus that signal satiety. So I'm wondering if ETI does the same, because we know it crosses the blood-brain barrier. So I'm wondering whether or not we should be counseling our patients to wait not 20 minutes after eating, but at least double that, 40 minutes after eating, to determine whether or not they've had enough to eat, because everybody talks about Trikafta munchies.
So I think that this is a really interesting question, and it makes me think of how broken the hunger and satiety cues are in our CF population at baseline because of what many of our adults grew up with as children with CF, being force-fed, being continually prompted to eat. I used to work in pediatric CF, now I work in adult CF, and it's sort of like I've gone through the lifespan and sort of seen the consequences of this. And I think I do hesitate to recommend somebody waiting 40 minutes to understand satiety because I do think that can get wrapped up in disordered eating patterns. So I would probably use that recommendation with caution. And I think that our next talk is going to speak a lot to body image disturbances, eating disordered eating patterns, and that you might get a little bit more information on how to help people reconnect with their hunger and satiety cues. There have also been a lot of really great talks at this conference about that are going to get shared out on the listserv. And we have a lot of great resources that are going around for you to use in clinical practice around helping patients with gentle nutrition and getting back in tune with those types of things.
That's great. Thank you. And we have to all remember that parents of children with cystic fibrosis feel so out of control over their child's health. So the one bit of control they have is to feed them and encourage them to eat. So I think that needs to be turned around as well, because they're always trying to feed their kids.
Yeah.
And it causes
Absolutely.
a lot of strife
Stress.
between them.
Absolutely.
Thanks very much.
Thank you for your question.
We're going to do one more question from the online. This is from Terry Schindler. Thoughts on concerns related to recent studies on the risk of bowel obstruction and pancreatitis with the new weight loss drugs? Should we proactively inform CF patients that this may be an increased risk and to be aware of the symptoms of both?
Yes. Absolutely.
Fastest answer ever.
Absolutely, Terry. I think that, add that to the list of things that we need to bring up. And it's not just informing patients, it's actually informing other clinicians. I think sometimes patients might be speaking to a physician and be desperate for weight loss and be begging for these drugs. And CF physicians aren't experts in weight loss medicine. And I think that it takes a lot to understand all of the negative consequences of these drugs. So it's not just educating patients. I think as dietitians, we also have to, on our teams, be educating everybody about the pitfalls and the side effects of these drugs that are very real and can be specifically harmful in our population.
Thank you so much, Juliana. And we'll have more questions for the panel at the end.
Okay, so moving on, our third speaker is Elizabeth Reed, who is an advanced practice dietitian at Children's Hospital of Philadelphia. Liz's journey started in clinical nutrition and has been practicing over 30 years with special interest in nutrition support, disordered eating, and pancreatic enzyme replacement therapy, and has spent last 17 years working with people with CF. She has published and presented at NACFC, contributed to the CF Nutrition 101 document, and participate in the CF Nutrition Dietitian Mentorship Program through the foundation. She was also past chair of the CF Nutrition Subunit of the Dietitians in Medical Nutrition Therapy Practice Group of the Academy of Nutrition and Dietetics. Thank you, Liz.
Thank you, and thank you so much to Juliana and Jessica, and thank you so much for inviting me to speak. So today, I am going to speak on the topic of body image, if I can figure out how to advance my slides. Yeah, I did that. Maybe I'll go down here.
Yeah.
There you go. Just do that. Okay. There we go. Okay. I have no disclosures related to this presentation. Okay, sorry. Okay. So today, I would like to expand a little bit about the topic of body image from the paper, just because I think people living with CF have had a long and complicated relationship with their body, which affects body image and eating. And so there's not a lot of research, and I want to expand into some research and some recommendation for the general population and talk about things that we all bring to the table in influencing our families and people living with CF. Body image. Our beliefs and feelings about our bodies are shaped by both internal and external influences, starting with our family of origin, our own experience, our culture, media influences, and how we think others perceive us. Body image relates to what a person believes about their appearance and perhaps how they think that they should look, and how they sense and experience their body, what it feels like for them to live in their body. Body image occurs over a spectrum from body dissatisfaction, when one might see their body in a distorted way, to a very positive body image with appreciation and complete acceptance of one's body. Along the way, many find acceptance, body confidence, and body peace, when although they might not like everything about their body's appearance, it doesn't hold them back from enjoying life and activities. You can't always look at someone and determine if they have a positive or a negative body image. It's not always related to size and shape, although a focus on weight can negatively affect body image and put people at greater risk for having body image disturbances. And of course, as we've heard, there is such a focus on weight from the very first visit with our people living with CF. Body image may also change and evolve over time. It may sometimes fluctuate over the course of years, over the course of months, weeks, and even in the same day. And unfortunately, there isn't an evidence-based program that I can present to you, but I can present some things that may promote more positive and compassionate attitudes about bodies. For someone living with CF, there are many aspects from the treatment of the symptoms of CF which may affect their body image, including scars from meconium ileus, resections at birth, clubbing, bloating, posture issues, thinning hair, too much hair, and additionally, we've heard a lot about these changes in body weight. And this focus on weight is nothing new for people living with CF. As we've mentioned, for many people, it's been a struggle to gain and maintain weight. And there's another group of people living with CF who, despite having significant CF lung disease, have never had a problem gaining or maintaining weight. And they feel it's a very sensitive topic because they feel they're discounted because they don't look sick enough. For someone who struggled with gaining weight, starting a modulator may have brought mostly positive effects on lung function and digestion, which have enabled them then to readily gain weight for the first time in their lives. And all of these groups may be happy or unhappy with their weight, and both groups may have a positive or a negative body image. And as we've mentioned, you can't really tell, shouldn't take it for granted when you're looking at someone if they have a positive or a negative body image. Some of the changes that our patients have mentioned to us since they've started on modulators, one of our patients told us that since starting ETI, they know for the first time what it feels like to really have a good belly laugh without coughing and coughing. And that, you know, for many of us is one of the greatest joys in life. And a great place to really see people with CF's candid opinions about reactions to weight gain is on the CF Foundation website. I've read many interesting blog entries. I read one from Elaine Malick, who talked about when she started tezacaftor, ivacaftor, she didn't have a great increase in her lung function, but what it did change and impact was her ability to gain weight. And she candidly talks about her adjustment to her feelings about what she called her new Wonderland body. She also says for the first time in 16 years of marriage, she and her husband could eat the same thing for dinner, which was huge for them. It was a quality of life metric that the care team couldn't measure. So the response to weight gain in people living with CF has really been varied, as has the effect on self-esteem and feelings of attractiveness in both negative and positive ways. Some people feel stressed that their clothes don't fit. Others say they just don't recognize the body that they're in now. And we've heard that some people say they are lungs-friendly work, but they just don't like feeling fat. Or they may feel empowered. They may feel that the weight gain is a great source of strength and survival. Or they may feel some complicated range of all of the above on the very same day and really need some time to adjust to living in this new physicality. Some people are really distressed and unhappy, and they may become so distressed that they sleep into disordered eating or eating disorders. Disordered eating is associated with an unhealthy preoccupation with weight and size. Eating behavior in all people, including those with CF, really occurs on a spectrum with healthy attitudes and behaviors towards food on one, which may include occasional undereating and overeating, to a more disordered spectrum that includes chronic meal skipping, missing insulin or enzymes, to an eating disorder, which are serious, potentially life-threatening conditions that can affect every organ system in the body. And it's also important to recognize that individuals at any weight, shape, and size can meet the criteria for an eating disorder. There's no validated CF-specific tool to definitively screen for disordered eating, but we do know that we have it, and there are some people who are working on this. Alexandra Cass et al. Surveyed a group of adolescents and young adults living with CF using standard screening tools and identified an increased incidence of disordered eating and eating disorders. So part of what's driving this is this multi-billion-dollar industry that equates thin with being healthy. And this is a very common false notion in popular culture. And there's a lot of misinformation about health that's driven by this industry, making us question our size, shape, and weight. Diet culture is a system of social beliefs and expectations that values thinness above all and consequently assumes people living in a larger body are unhealthy, which is totally untrue. And as Juliana mentioned, this false notion drives weight stigma and may make people living in larger bodies less likely to pursue needed health care. There's an excellent video on weight stigma in healthcare that I would highly recommend. It's from the Rudd Center at the University of Connecticut, and it's listed in my resources. So again, our focus on weight is something that we pay attention to with good reason from the very beginning in promoting optimal respiratory health. And we start out life, we're thrilled with our bodies. We point to our bellies with no judgment. As providers, we can, from the beginning, promote images of necessary weight gain by discussing growing taller, stronger, becoming well-nourished, vigorous, robust, never overweight or fat. Sports nutritionist Nancy Clark refers to athletes' target range for peak performance near the 50th percentile BMI as the power zone. And I think that this is a much more positive way to really, and you also can then be a little bit vague sometimes about where exactly you need someone to be. But it's a way to promote normal development in a very positive way. Adolescence is a time of huge change, and they are especially vulnerable to diet culture and media messages, feeling different from what they may perceive as the cultural norm. We've all survived adolescence, and though I don't know if any of us would want to do it again, it's a time of great transition for both hormones, weight, size, with a weight gain of 25 to 30 pounds, and up to 40 pounds often for boys, and a redistribution of body fat. We may not always appreciate where that body fat ends up. Some navigate their body image well, and some just fine with a few bumps, and that's most of us. And some develop fears and perceive all of these changes as very negative, and this is a time for greater risk for developing disordered eating and eating disorders. Those first talks about bodies are happening at home. Children are little sponges, and they're soaking up what their parents are modeling. Modeling is something that we need to keep in mind. No matter what we say in clinic, what we model is the loudest voice, and what families model at home is also the loudest voice. So what parents are modeling in terms of body and food talk, forming core beliefs about eating and body image. I've had some parents who really struggle with this. They've struggled with weight in their lifetimes, and they may have struggled with disordered eating and eating disorders. So this is a particular challenge for them as well in this conversation that can be very focused on weight every 3 months in a clinic visit. Caregivers can help kids identify what they're experiencing in their own bodies. We can start out talking about hunger cues from the very beginning. Are they tired? Other feelings? Are they scared? And then just the miracle of having a body and all it can do and how we take care of it. And then, of course, because we're modeling, the challenge is we have to model taking care of our bodies and saying kind things about our bodies, being kind to our bodies. Modeling flexible eating, limiting food rules, demonstrating that they can appreciate their own body and different sizes and shapes of other bodies. Caregivers can really help get little ones off to a good start. And there is some research that shows that if children start with good modeling of body image and eating at home in early years, it makes them less susceptible to some of the false media images that they may encounter later in life and from other external sources. We need to celebrate body diversity. Each person's genetic inheritance influences their bone structure, body size, shape, and weight differently. And we have to appreciate those differences, encouraging healthy behaviors and treating everybody with respect. These are all female images, but boys and children of all gender identification need this. It can be a real battle for all of us to push back against societal pressure to look a certain way, but we need to appreciate and vocalize that healthy bodies can come in all sizes and shapes and find ways to accept the aspects of our bodies that can't be changed. It's not realistic to expect to be totally satisfied with one's body throughout life, but learning to accept and see it as beautiful in its own way and capable of many things can be very liberating. The way we feel about our bodies can change over time. It doesn't mean the journey is easy to get there, but we can't minimize how someone may be struggling, but we need to validate their feelings wherever they are. Two approaches that can help promote body promote acceptance of one's body are body positivity and body neutrality. Body positivity encourages loving and caring for your body, and body neutrality promotes accepting your body as it is and recognizing its remarkable abilities and non-physical characteristics. Body neutrality means that you don't always have to love your body, but you can still live happily in your body and appreciate all that it can do, such as dancing, hugging a child, or carrying groceries. Body neutrality encourages mindfulness, because once you respect your body, give it care, nutrition, and movement, you'll notice just how well that you begin to feel and how well your body functions. You don't have to choose one or the other of these. I like to combine. I think they're all good ideas, and I just combine all of the above. So hand in hand with diet culture are the unreal images that promote ageless perfection, because again, we all change as we age as well. And we need to know what we're really looking at. Norway passed a great law requiring labels on retouched photos in social media. We need to become critical viewers of social and media messages. Pay attention to images, slogans, or attitudes that make you feel bad about yourself or your body. In studies they've done of people looking at images of stylized, slim figures that are very acceptable to diet culture actually makes people feel worse about their bodies and their body image. So we need to talk back to those images because they're unreal. They're not only in advertisements, but in our social media. And we need to curate our media feeds, even take a fast. But if we curate our media feeds, you can change that algorithm so you start getting back, messages that reinforce body positivity and age-affirming images and messages. Affirmations can help develop more positive body image. These are from a book by Lindsay and Lexi Kite called More Than a Body. Your body is an instrument, not an ornament, and your value is not measured in pounds and inches. Your true value lies inside you, not outside you, and I am worthy of love and respect, no matter what size I am. The body story is a concept that I first heard about when I took a training that was offered by the Body Trust Group from Dana Sturtevant. I'm really butchering her name. Sturtevant, and Hillary Canavy. And you can build compassion for your body by thinking about its journey. And I think this is especially true for anyone with a chronic illness such as cystic fibrosis. There are lots of prompts listed on their website, and these can be very helpful. I'm going to speed up a little bit because I think okay. So what really goes into our health is so much more than body weight and BMI. Social determinants matter as much or more than our health behaviors, but we can help. We can help our patients really learn about what goes into health, and it's not just weight. We can help patients navigate this landscape by promoting habits that will benefit their long-term physical and emotional health. Just a little bit more about weight-inclusive care, focusing on joyful movement, intuitive eating, improved sleep, and stress reduction actually are just as potent promoters of health. And as providers, we need to listen, to carefully listen to what really matters to our families. PEP teaches us to ask at the beginning of the visit if there's anything that you want to make sure we discuss today. We want to not assume anything about someone's lifestyle behaviors based on their weight. And we want to ask people with CF about their habits in the framework of health, not weight. focus our interventions to improve health, not weight loss. And I want to put in a plug for this Tips for CF Care Teams, Conversations About Body Image from the Mental Health Advisory Committee. It's really an excellent resource. It is not a handout for patients. It's for us. It's for us to look at our opinions about unconscious bias. There's links to some studies where you can look at that, and also weight stigma. Here's some non-appearance-based compliments. You know, sometimes it's just so common if you say, oh, it's great to see you. You look great. Have you lost weight? But if you're complimenting weight loss, you may actually be complimenting disordered eating. You may be complimenting cancer. You may be complimenting someone's depression. So it's good to compliment people that we are glad to see them. And if you need to compliment, some people just avoid the conversation altogether, but you can be glad to see somebody and compliment something about their outfit or something that they've done or some way that they made you feel or that they always smile or something positive that's not directly related to weight. And just modeling a healthy image for young people. Just in summary, making positive comments about your own body and all bodies, and that they can come in all sizes and shapes, setting a positive example of healthy and balanced relationship with food, and helping children accept and enjoy their bodies and encouraging physical activity. Encourage critical thinking of media is huge, and representations. Devote yourself to raising non-sex stereotyped children by modeling living gender equality, encouraging children to talk openly and honestly and really listen to them, and develop a value system based on internal values. These are all from the NEDA, the National Eating Disorder Association website, and I would encourage to read the entire article. CF is a really needy disease. If one thinks about their body weight and size in a negative way for even 5 minutes a day, that's 30 hours a year. I don't want anyone to waste a minute of their lives. Just another resource that I think is really great is this body image and cystic fibrosis book that came out from Jacqueline Didsbury and the UK Trust. There was a new issue in 2019. The original issue was actually, I think, in 2011 that she did with Emily Thackeray. Unfortunately, both Emily and Jacqueline have passed, but this booklet really echoes the voices of people with CF and how they feel about many issues about body image. CFresh is a collaboration of patients, clinicians, and researchers. And again, there's a great section on body image, some resources, and that's it. Thank you so much.
Thank you, Liz. That was a great. I'll start with a question from the app, but if anyone has any in-person questions, please come to the microphone. This is from Jessica Mueller. When discussing body image and eating habits, where does the line of scope of practice come into play between dietitians, mental health providers, social workers, and physicians? So sort of how do you figure out who does what?
It's an excellent question, and I think you have to do what you feel comfortable with. And I would talk to your care team about it ahead of time. And I actually often partner with our social workers in these conversations about body image and disordered eating. So, and sometimes because we have multidisciplinary visits, sometimes they're easier to have outside of a clinic visit.
Hi, I'm Sarah Lussman. I'm a pediatric GI at Columbia University. So the new position on an individualized approach is so needed, but it's definitely a paradigm shift for a lot of people who have been doing this for a long time. And I've noticed that even within our own care team, there's still sort of a lot of undoing that we have to do at many visits. And I have a great partnership with my dietitian, and we really try to drive and reframe the conversation with patients and families. But sometimes I think that there's conflicting advice coming from, anytime you have changes, there are early adopters and late adopters. So you gave us some tip sheets, but I was just wondering, in your personal experience, if you could share any of your own tips for helping some of the late adopters on the care team kind of reframe their thinking about this.
This is an excellent question, and I think it's very timely. I think it's something that there was an excellent presentation previous to this one that really focused on some of these things. And we can put out some of those recommendations because it was so helpful, and it'll go beyond like a 30-second, quick answer that I can give you. But I think depending on when many of us trained, like I've been doing this for a while, and I trained in the old paradigm. And I learned through experience because I was the one who was sent in to fix people. But I quickly realized that they weren't broken, that maybe this whole system we had to try and change people's body sizes was what was broken. And so that was a whole evolution for me. And also, we know there's some really negative consequences to people regaining weight and weight cycling. So I think it's going to take individual conversations and a lot of education. And one of the ways I think we can start is maybe as we're talking about what we learned at the conference, what was new, like what was that one takeaway that you're really going to think about, we can bring this up and really talk about doing no harm, and promoting the best for people living with CF.
We have time for one quick question.
I was just going to be Terry Schindler for a second. And if you want more information about this, put it in your evaluation so that we can continue to have the conversation. Your evaluations matter. So if this is an important topic, make sure across your disciplines that voice is heard.
That's a great point, yeah. So thank you so much, Liz, for your excellent presentation. Moving on, our final speaker, Ms. Judy Felton. She's a dietitian and program coordinator at Children's Hospital, Colorado. She started her CF journey and currently over 30 years working at 3 different hospitals. Initially, she started at Children's Hospital of Pittsburgh in Pittsburgh, Pennsylvania, and later moved on to Johns Hopkins All Children's Hospital in St. Petersburg, Florida, and currently at Children's Hospital, Colorado. She earned her MPH in epidemiology from University of Pittsburgh and her bachelor's from Indiana University of Pennsylvania in nutrition. Since 2007, Judy has served as a clinical nutrition mentor with the foundation. And also she has been a nutrition representative for the CFF Steering Guidelines Committee and a member of Foundation's Food Security Committee. Judy has co-authored several book chapters and manuscript and presented multiple times both nationally and locally on CF nutrition. Thank you, Judy.
Thank you. Okay.
Oh, no. Oh. Wait. Is the tech person still here?
Oh, you did it.
Oh, I did it. Okay.
Okay.
So it should you have from the clicker?
We got it. Okay, so thank you so much. And I have no relationships to disclose on this presentation. So like Amanda had mentioned, and I feel like no one can see me, but the nutrition position paper was a multidisciplinary working group of medical professionals, and we were formed to help provide interim advice on nutrition topics in this current era in both adult and pediatrics. and we developed a 20-question survey about challenges and concerns around nutrition-related issues. We distributed it to both CF centers and to people with CF, and we had over 600 responses. So today I'm going to be presenting on food insecurity and also on salt. So we defined food insecurity in our paper as a lack of consistent access to sufficient amounts of affordable, nutritious, and healthy foods. So we also talked about the prevalence of food insecurity. One of the papers from 2019 showed that up to 33% of people with CF were impacted by food insecurity. At that time, that was triple the national average. And of note, this was before the pandemic and also before Trikafta. We also discussed in our paper that food insecurity is multidimensional in nature. These financial constraints require balancing between food and other household expenses. For example, when our patients come to clinic, sometimes they miss work, and all of a sudden they're losing a whole day's worth of work just to come and see us. This is a hardship. In addition, co-pays on medications. And again, I feel like this is the number one topic that we hear about now is the patient's concerns about paying for medications. It's a trade-off. They're paying the co-pays, but sometimes that's taking away from the money they're using to buy food. The impact of food insecurity, a paper in 2022 discussed that the impact of COVID on food insecurity and mental health and self-care in individuals with food insecurity may be higher rates of stress, depression, and anxiety, more weight loss, poor medication and dietary compliance. Again, this 33% of your population that's struggling with food insecurity, they're being impacted every day with this. Some other things we noted in our position paper with regards to food insecurity is that it's a concern in people with CF from all socioeconomic sectors, and screening should be part of standard CF care. The other thing we noted was that in this new era of CF care, and the focus is on quality calories in the diet, these quality calories, healthier foods, are more expensive. This is a new concern in CF. And I think of it as not just having enough food, but having enough nutritious food. So when we did our research, we realized that the timing from the CF Foundation was wonderful, because in 2018, this CF Foundation had started a food security committee. And again, this was comprised of medical professionals, patients, and family members. And their goal was to raise awareness of food insecurity and address and better understand it in the CF population. Okay. All right, it worked. All right, so over the next couple of years, the Food Security Committee published several data and resources they developed. They identified and addressed food insecurity. They also, if you walk around this conference, there's more presentations on food insecurity. There's more abstracts on food insecurity, which I love to see. There's just more research, more awareness. And then in 2021, the CF Foundation surveyed the centers in the U.S. and found that 91% of the CF center teams were screening for food insecurity. This was compared to 50% in 2017. So again, we're screening more and we're raising awareness. From the Food Security Committee, there was several publications. The one I wanted to highlight was from Juliana Bailey just this past September on food insecurity and local food access, the contributions to nutritional outcomes among children and adults with CF in the United States. Some of the take-home messages: one, more frequent food insecurity screening is associated with less underweight in children with CF. As I'm presenting, I'm going to explain why, but again, it's just looking and listening. The next is residents, patients who are living in food deserts. It's associated with higher odds of being underweight in both children and adults with CF. For those of you who aren't aware, a food desert is a geographic area where it's difficult to find healthy, affordable food. So when I'm talking about looking and listening for food insecurity, again, I've been a clinician for over 30 years. And like some of us, we meet these patients and some stories really stick with you. And I want to just share a couple patient stories because these are the ones that motivate me, and hopefully they'll motivate you. NJ is one of those patients who lived in a food desert where he didn't have access to a lot of healthy food choices. He actually walked to the dollar store to buy his food frequently because to go to a grocery store required him driving there, and it was an expense. So when NJ got admitted for a pulmonary exacerbation, and he was up on our floors, he would not order one, but he would order 2 trays of food. And he would just eat these foods ravenously. And again, he loved our food. Nobody loves our food in the hospital. He loved our food. And he would gain several kilos during the admission. And I see some of you nodding because you might have seen an NJ over your years. And again, it's looking and listening for food insecurity. AM is another patient that I just wanted to tell a little story about in regards to food insecurity. AM was only 5 years old, and when he came to clinic, he had a history of intermittent abdominal pain and loose stools. He was getting a lunch and a breakfast at school. He was eating a cooked meal at home, but he had no other snacks. We discovered from talking to him in clinic, he actually kept a case of formula underneath his bed at nighttime. And he would, when these stomach aches came, we realized they were hunger pains, he would pop open a can of Pediasure and he would drink it to get rid of his abdominal pain. And he wasn't taking enzymes. So again, this is just another example of looking and listening for food insecurity. And interestingly, neither of these families, when they were completing our food insecurity screeners, the hunger vital signs, neither of these families answered yes to food insecurity, but yet they were struggling. So I think this is just another example of how important it is to both look and listen for food insecurity and to understand your patient's whole story when seeing them in clinic or as an inpatient. Next, I'm going to talk about and give an overview of food insecurity resources to support CF care team members and the CF community. There's so much out there. Hopefully, most of you are familiar with this website. It's my.cff.org. And when you log in, you can select the resource library and then search food insecurity. There's a QR code up here, and if you're not familiar with it, please take a picture of it now, bring it back, because when you get home, it will take you directly to the Food Security Index. And on this index, we talk about the definition of food insecurity. There's resources to learning about food insecurity. There's a whole quality improvement change packet, so you can start working and screening and educating your whole team members. Because again, everyone needs to look and listen for food insecurity. Screening, intervening, and advocating, which again, I think that's been a topic during this past NACFC, advocating. An example of what's available under the intervening, and again, there's so much information. There's handouts for patients and families. There's information on how to start a food pantry. There's unique interventions on food insecurity, activity pages, and then WIC medical referral forms. Your patients WIC stands for Women, Infant, and Children. It's a federal program. Women who are pregnant or breastfeeding can be referred to WIC. Also, infants and children up to age 5 can be referred to WIC. It's probably one of the most underutilized programs in the U.S. and is so helpful. Under the screening index, there are these are all validated screening tools. There's a lovely webinar on screening and sensitivity with sensitivity. This is using PEP skills, because again, talk about a hard topic to talk about. Food insecurity is one of them. And this webinar is very nice to review and talks about how to talk to your patients about this kind of touchy topic. And then also food insecurity screening logs. So from our nutrition position paper, we had a lovely algorithm that we had published, and this is also available under this food insecurity quality improvement change packet. But there's 6 steps with screening and intervening, and I just wanted to go over this real briefly. Besides, initiating the process and asking the question, next is interpreting the results. Then, if somebody screens positive, it's really important to see if they have enough money to go home, if they have enough food at home when they get home, if they have enough gas to get home. Those are like the immediate responses. And at that point, you can possibly give food cards or talk to them about a local food pantry. Then the other step is like long-term. How can we help you and make this easier? And that's where the resources I mentioned earlier can come into play. Then, it's important to document this. If you don't document it, we don't know it happened. So make sure you document what you did and the resources that you used. Step 5, very, very, very important. Following up, finding out what worked. What didn't? Why didn't it work? What were the barriers? Rescreening at that next visit, and then completing the documentation. So one resource alone won't be enough. And I think all of us agree in this room, if you look at all these different resources, most of your patients are utilizing 1, 2, or maybe all of them. But this takes time. It takes time when you're in clinic to meet with the patients, to make these referrals. And healthcare is crazy. So right now, it's hard for people in your clinic to make these referrals. Compass, and I know most of us are familiar with Compass, but utilize Compass to help your patients get resources and to help you be able to provide these resources for your families. One of my favorite resources is this one. This is from Hunger Free America, and it is a resource that actually Paula Loomis, somebody sent out over the summertime. And this is the best resource ever because it's so easy. If you take this number for Hunger Free America and you text the word food, it will then send you a little link to enter your zip code. At that point, you put your zip code in, and it will list you a whole bunch of resources based upon your location. These are local resources. You can walk to them. They're in your neighborhood. And these are food pantries and food banks, and it's just a lovely way of getting resources close to home and helping your families. So definitely take advantage of that one. So in summary for food insecurity, from our paper, food insecurity is a concern in people with CF from all socioeconomic sectors. Food insecurity screening should be part of standard CF care as it helps link patients to services. We, and a lot of, in our position paper, we suggest screening at every visit. Make sure you're looking and listening for food insecurity. Identify patients and families that live in those food deserts because they are at higher risk. More research is needed to understand the screening and the intervention that is most effective in the CF care facilities. keep doing those abstracts, keep looking and listening and writing up these results. And know and use your resources. There's the local resources, there's the national ones, and then there's the federal ones, like the WIC. So make sure you utilize them. So now I'm going to talk about the salt part of our nutrition paper, kind of just switching gears. So I think all of us know that salt, there's a very long history of salt in cystic fibrosis. So as we did our paper, there was a lot of facts. Things like excessive salt loss and sweat can result in inadequate levels of sodium in people with CF of all ages. I think we all agree on that. Adequate salt intake is needed for optimal growth in infants and young children. For those of us in pediatrics, human milk and infant formula provide adequate sodium for full-term non-CF infants. However, sodium deficiency can be problematic in infants with CF. We have specific guidelines for supplementing salt in our infants and young children with CF. Special guidance regarding fluid and sodium needs should be given to athletes with CF during those physical exertions and those big exercising times in hot conditions. And again, these are things that have been researched, have been studied, and these are a part of our current guidelines. So our current guidelines suggest increased salt intake in all people with CF as a function of dietary need, level of physical activity, and climate. So during this time of highly effective modulator therapy, we can see significantly reduced salt losses, a reduction of salt losses in sweat. But at this time, there's just not enough evidence-based research for us to actually change our current salt recommendations. And after all our research, we kind of walked away saying there's just not enough research yet. But we do know hypertension is increasing with our patients with CF. Hypertension in people with CF may be attributed to longer life expectancy and more overweight patients since the availability of the highly effective modulator therapy. But again, at this current time, when we did our position paper, we felt there was lack of data to make specific suggestions about salt intake, even with hypertension. So where do we go? We know that we need to use clinical judgment and individualize our dietary salt recommendations for certain high-risk CF patients, post-organ transplant, advanced hypertension, and do more research. So I wanted to just shake up salt in our diet and just talk about my thoughts of where I feel we should go. I think we need to start continuing to talk to our patients about salt intake. We need to look at our patients' diets, see what types of foods our patients are eating. A lot of our patients are relying on processed foods, and especially, again, ones with food insecurity. Those are ones that it's easier to get access to processed foods. And 70% of salt in our diet comes from the foods that we eat. And the high salt foods, things like frozen dinners, deli meats, salted snacks, ramen noodles, things of that sort, very high sources of sodium. A lot of our patients, especially the adults, they're so used to just shaking the salt on their diet. They don't even stop to taste the food first to see if it even needs salt. I think one of the things, it's like breaking habits, changing habits, and just how we're trying to, change the legacy diet. I think we need to look at the salt and how our patients are using salt. So to ask your patients to start tasting their foods before they salt them. And then looking at the types of salt that they're using. There are types of salts that are a little bit lower in sodium, maybe using a Himalayan salt over table salt to just get a little bit less sodium in your diet. I suggest sometimes salt-free seasonings. There's such a great variety of them out there. One of my favorites is Penzeys, and Costco has them too. Very, a combination of different spices, no sodium in them, but it can flavor your foods without using any salt. Again, just kind of an education of their diet. And lastly, I think it's important to talk about electrolyte products that patients are using for hydration. These electrolyte contents in these products can vary greatly. Some of the ones that I see, and again, living in Colorado, it's super dry, though I think it's dry here. The electrolyte content of a packet of Drip Drop or Liquid IV, if you look at the fine print, over 500 milligrams of sodium in that little packet that you're adding to a bottle of water. If you get a Gatorade, that's half the amount of salt in a Gatorade. Gatorade has about 240 or so, typical Gatorade. There's lots of different ones out there. But again, look and see what your patients are eating, see what your patients are drinking when it comes to the sodium. And that's my presentation, so I'll be glad to take any questions. Thank you.
Meg Sate from Dallas, Texas. Quick question about the salt. Do you think that there's any role for, looking at urine sodium in some of these patients to see whether we're overshooting or not? I mean, we look at the blood pressure and things like that, but in the kids, we've used it sometimes in our kids, our infants especially, like kind of adopting from intestinal failure. If despite good calories, despite parents are feeding, enzymes are good, and the patient is still not growing, to see whether we need to go from a fourth to a half teaspoon earlier than the recommendation. So wondering if you could use it in reverse.
You know what? And that's where I think the research needs to happen. I mean, we use it with our NICU patients in the hospital. I think it's I want to see an abstract on it. Definitely. Thanks.
I'm a dietitian at Children's of Wisconsin. So I haven't read the position paper. Is there a recommendation on enteral nutrition for any people who use it? Because so many of the products are very low in sodium.
Yeah, and you know what? There's not, right? I'm looking.
Yeah,
all these guys
there's
were
not.
authors too.
So the position paper was just new topics that people were had been asking questions about. Like we surveyed the CF community. There is the enteral feeding guidelines from 2016. And I do not believe we addressed salt at all. I was one of the authors. I apologize for not remembering, but I think we just assumed that we would, people would look at it, but I don't think that's something anyone's ever looked at. That's a good question.
Yeah.
Hi, just a quick clarification for the salt. This is Monica. I'm the dietitian at Allentown Children's Hospital. So as we're working with our CF patients to move towards less processed foods and more whole foods to manage their weight with ETI, are you saying, so if a patient does do that for me and they're eating whole foods, fruits and vegetables, do I still want them to add salts to those regular guidelines? Is that what you're saying? Because a lot of them are doing a lot of processed salts, and if they get them to reduce that,
right,
it's kind of a mixed message. I just want to make sure.
So right now, again, I think it's going to be individualized. I really do. But we just didn't feel like there was enough evidence yet to start making specific recommendations. So, but if I see a patient who's eating a lot of, if I know they're getting enough salt in their diet and they don't want that salt added, I'm not suggesting it.
Really? So we could say don't add salt.
Yeah.
That's new.
If you feel, again, I think it's like an individualizing it, personalizing it. We do look at sodium levels. Now, if they're starting to go jogging and things of that sort and exerting themselves, they may need more. But again, I think it's going to be more individualized.
Interesting. Thank you.
Mm-hmm.
Also, just to tag onto that, if they've had a sweat chloride that's normal, then I think that people are starting to think if your sweat chloride's normal, then maybe we don't need more salt. I mean, that's what we do at our clinic.
So we're not, sorry, Kim from Columbia University Medical Center. So we're not repeating sweat chlorides. I guess they are if they're in the studies, but we don't have access to that. So I guess I've been asking patients, are you still seeing salt crystals when you sweat? So I'm kind of using that as a guide for my adult patients. So is that appropriate, or is there something else you suggest? And I will also say you do need to be careful with the electrolyte supplementation, because I did have one patient who I told him when they're at the beach all day, they should use a supplement, and then he continued it, and the patient ended up with extremely high sodium levels, and we did not realize that he had continued it. And then eventually he said, "Oh my God, I forgot that I continued this."
Yeah.
And he stopped it. So it's sometimes patients do not continue to tell you when, and actually it's a patient that has CP, so it was really the dad. So it's kind of important to know, are they not necessarily following what you're recommending? So it is very important to, only do it sometimes.
Right, right.
So
It's a great area for research abstracts for next year.
It is. And back to, because we do sweat tests at our center, and we do them for research. We also do some clinically, and the results have been a little varied. But I have been getting, more and more families telling me I don't see the salt crystals like I did before. We're individualizing the recommendations. We're in a pretty active state, so I feel like, and it's dry, and we do continue doing the salt supplementations. The electrolytes, I think you and I had this conversation before, because people are using them and they don't use them properly. And it's really scary. And people don't realize how much sodium's in them.
And I actually have a list of salt supplements, and I have the sodium content on it. And I actually took off the chews that we were talking about that had sodium citrate because they need the chloride. So.
Yeah. So, thank you.
One final question. Yeah.
Hi, I'm Sarah from Vanderbilt. So I think I've introduced myself at other sessions before, but so Nashville, Tennessee, we don't have the best diet quality, but it is also extremely hot, and we are the complete opposite of dry heat. We are 100% humidity. So I'm sure you can imagine that my patient's salt losses, especially over the summer, despite being on modulator therapy, are excessive. Even if you don't have CF, I will literally find over the summer salt crystals on my skin. But so my question is, so especially in our infants and younger kids, we do a lot of checking urine sodium if symptomatic of poor growth despite nutritional optimization. And what's nice is that typically TennCare and other insurance companies will actually cover sodium chloride tablets. So if we want to back calculate in terms of milliequivalent per kilo, because a lot of my babies and little kids need around 4+ milliequivalent per kilo, I will use that instead of just table salt until they're in a better place nutritionally where we can just liberalize their diet with table salt. But so my question more so is for older kids, especially in instances of heat and, excessive sweat. If they do check a urine sodium and it is low, is there any kind of objective parameters in terms of milliequivalent per kilo to aim for? Because if we can use a sodium chloride tablets and really prescribe salt as a medication, is that potentially better, just again, to have more control?
Yeah, so very interesting. We did not get into that part. When we were doing the research, there was just not any research out there on, your type of scenario. I think it'd be so interesting to sit down and look at salt needs across different climates starting there and seeing, again, it's such a little piece of CF, but it's such an important piece. And I think oftentimes it gets forgotten. So, again, I think collaborating with others and looking at it, I think would be the first step.
Yeah, I will say that common populations that I overlap with these health questions happen to be our cardiology and our NICU population.
Yeah.
That they are frequently utilizing salt supplementation as well for their babies and little ones that are growing poorly.
Right. Interesting. Thank you.
Thank you so much, Judy. So we did not get, obviously, time for the panel because we ended up with lots of questions there are a few questions that people asked on the app, and we're just going to ask the speakers to come up and answer those on the app. So if you asked a question that didn't get answered, you should hopefully get a response within a few minutes. And thank you all for staying to the very end. We're almost done.